Hi everybody and welcome to our module on fluids. Let's start by reviewing the fluid compartments in the body. The body is made up of 60% water and 40% non-water. And of all the body water, the majority of it, 2/3, is found within inside cells. For the 1/3 that's found outside of cells, the majority of that is interstitial fluid in the tissues, and only 1/4 is found in the plasma. A normal person takes in about 2 liters a day of free water, and they must put out 2 liters a day to remain in balance. About half of that goes out in the urine, a little bit goes out in the stool, and the rest goes out through what are known as insensible losses. And mostly your insensible losses are water vapor that goes out when you exhale, and also loss from sweat through your skin. And you should be aware that insensible losses go up in many pathological states. When patients have a fever, they will sweat and they will also have more water vapor found in the air in their lungs, and for this reason they will have more insensible losses. The same is true in patients who have burns. They can lose lots of water that would normally be contained by the normal skin. So now we're going to talk about the types of intravenous fluids that are administered to patients. If you think about the history of medicine, few things have done more to save lives than the development of the ability to infuse fluids. Many people died ages ago because they simply were volume depleted. Now that never happens because we can place an IV and infuse intravenous fluids. And there are basically 5 types of intravenous fluids we use clinically. They're all listed here, and we'll go through them in the next few slides. Let's start by talking about normal saline. And any time an intravenous fluid has the word saline in its name, that means it is made up of sodium chloride. In normal saline, you find water and sodium chloride. The amount of sodium chloride in normal saline is 0.9% weight per volume, and therefore normal saline is also called 0.9% normal saline. And the amount of sodium chloride found in normal saline gives it an osmolarity that is approximately the same as plasma. Normal saline has 154 milliequivalents per liter of sodium chloride versus 140 in plasma, and the osmolarity of normal saline is 308 milliosmoles per liter versus 285 for plasma. So because these numbers are so close, we consider normal saline to essentially be isotonic with plasma. What that means is when you infuse normal saline into a vein, it will enter the extracellular space and it will stay there because fluid only moves between the extracellular and intracellular space when there is a change in osmolarity, and there's no significant change in extracellular osmolarity when you infuse normal saline. For this reason, normal saline will distribute in the extracellular space just like any fluid in the extracellular space. 25% will go to the plasma, meaning it will stay within the vascular system like the arteries and the veins, and 75% will enter the interstitial space of tissues. And I've reflected this in my second bullet point here. 25% of infused normal saline remains in the intravascular space. And because a significant proportion of infused normal saline remains in the intravascular space, this makes this a very effective intravenous fluid for volume replacement. When patients have serious conditions like hypovolemic shock or septic shock, their blood pressure can become dangerously low. So you want to use a fluid where a significant proportion of the fluid is going to stay in the vascular space and raise the blood pressure. And that's where normal saline is useful because of its properties being nearly isotonic with plasma. As I just told you, normal saline contains chloride, and chloride is a negatively charged molecule, and therefore anytime you infuse normal saline into a patient, you are infusing chloride ions into their plasma. In the plasma, there's a balance between positively charged ions and negatively charged ions. Most of the positively charged ions are sodium, and the sodium is balanced by negatively charged ions like chloride, bicarbonate, and then a small collection of other substances like proteins, phosphates, and sulfates. And the amount of all these substances together is called the anion gap, and this is important when we talk about acid-base disorders. So what happens when you infuse normal saline is the amount of chloride goes way up. That's going to cause bicarbonate to shift into cells so that the amount of bicarbonate will go down, and this is done to maintain the balance between positive and negative charges. As a result, anytime you infuse normal saline, you shift bicarbonate into cells, and that causes an acidosis, meaning a drop in pH. And any time a patient develops an acidosis, that means there will be lots of protons outside of cells. What will happen at this point is cells will bring protons inside in exchange for potassium going out. This means that anytime you have an acidosis, including an acidosis from normal saline infusion, potassium will shift out of cells and there will be a rise in the serum potassium. This is a normal response to the acidosis of infusing normal saline. Second type of fluid we'll discuss is lactated ringers. Lactated ringers is a fluid solution that contains sodium and chloride just like normal saline, but also potassium, calcium, and lactate. And because it contains all these extra elements, it's called a balanced fluid in contrast to normal saline, which is not considered balanced. It's isotonic with plasma, similar to normal saline. It has an osmolarity of 286 milliosmoles per liter. And what makes lactated ringers special is the lactate gets metabolized into bicarbonate, and the bicarbonate acts as a buffer in acidotic states. So for this reason, its most common use is in trauma resuscitation. Patients who undergo trauma often develop a lactic acidosis, and so by using lactated ringers, which will give some bicarbonate, this helps to offset the acidosis. And in case you're wondering, lactic acid dissociates into a proton and also lactate. So lactate is the conjugate base of lactic acid. So when you infuse lactated ringers, you're infusing lactate, not lactic acid, so you won't make the acidosis worse. And because the lactate can be metabolized into bicarb, you're adding bicarb, which offsets the acidosis. And one reason sometimes people are hesitant to use lactated ringers is because it contains potassium, and there is concern that this could cause hyperkalemia. However, you should be aware that lactated ringers do not cause hyperkalemia. And the reason for this is because the concentration of potassium in lactated ringers is lower than the normal concentration of potassium in the plasma. So even if you give lactated ringers to a patient who has hyperkalemia, you will bring the potassium concentration down because the potassium concentration is so low in the lactated ringers fluid. Because normal saline and lactated ringers are both essentially isotonic with plasma, they're both fluids that can be used in patients who have shock. And for years, people debated whether one was better than the other, and surgeons preferred lactated ringers, and medical people preferred normal saline. In 2018, however, there was a trial done to address this question called the SMART trial. You should be aware of this. It will come up on rounds, and if you can reference it, you'll look like a superstar. So this study was published in the New England Journal in March 2018. It took 15,000 critically ill patients who needed fluid for various forms of shock, and patients were randomly assigned to receive either normal saline or lactated ringers. And the study found improved outcomes with lactated ringers. The outcomes in this study were death from any cause, new renal replacement therapy, meaning new dialysis, or persistent renal dysfunction. So because of this trial, a lot of people think we should stop using normal saline and switch to lactated ringers for most patients who need fluid resuscitation. Not everyone is switched over, and not everyone believes the findings of this trial, but you should definitely be aware of it when you're rounding in the intensive care unit. Half normal saline gets its name because it's got half the concentration of sodium chloride as normal saline. It's also called 0.45% normal saline. And this intravenous fluid is hypotonic compared to plasma. What that means is it's not going to remain in the intravascular space. It's going to diffuse into cells. That makes this not a good form of intravenous fluids if you want to volume resuscitate a patient, because the fluid is going to leave the intravascular space and go inside of cells. What this is good for is what's known as maintenance fluids. So there are many patients who are sick in the hospital, and for one reason or another they cannot eat and drink normally. So by infusing half normal saline, you replace their daily and sensible losses of sodium and water. Sometimes 5% dextrose is added to it. When this is done, it's sometimes called D5 half normal saline. And sometimes potassium is added, and when this is done, it can be called D5 half normal saline with 20 milliequivalents of potassium or 40 milliequivalents of potassium. And the idea here is that by adding potassium and dextrose, you are giving more nutrition to a patient who may need it if they're not eating and drinking. Patients may be losing potassium in their urine. They need the dextrose as a source of energy, and so you can give this to them through an intravenous fluid by using half normal saline with dextrose and potassium. And once again, as summarized in this last bullet point, this is the type of intravenous fluid often used when oral intake is very low. D5W is an intravenous fluid that contains dextrose and free water. When you infuse this into a patient, the dextrose is slowly metabolized, leaving only free water behind. As a result, this is the type of fluid that you use when you want to give a patient free water without having them drink. In other words, you want to give free water intravenously. You can't directly administer free water to a patient because it will cause cells to lyse, but you can administer water with dextrose in it, and then when the dextrose is slowly metabolized, you have essentially given that patient free water. And because this is equivalent to giving free water, this is the ideal fluid when treating hypernatremia. If the sodium level is very high, by giving D5W, you will dilute the sodium back down to a normal level. Hypertonic saline is also called 3% saline. This form of intravenous fluids contains the highest concentration of sodium chloride that we use clinically. Because of its high concentration of sodium chloride, it is hypertonic compared to plasma. It has an osmolarity of approximately 900 milliosms per liter. Because its osmolarity is so high, it will tend to draw fluid out of tissues and into the vascular space. And in general, hypertonic saline is only used in two circumstances. The first one is when patients have elevated intracerebral pressure. Patients who have had head trauma or intracerebral bleeding can have very high pressure in the intracerebral space. What hypertonic saline will do is draw fluid out of the brain tissue, and that will tend to decrease the intracerebral pressure. The other situation where hypertonic saline is used is in severe hyponatremia. In patients in whom the sodium is very, very low to the point where it's becoming life-threatening, hypertonic saline can raise the plasma sodium concentration back towards the normal range. When talking about intravenous fluids, you will hear people use the term crystalloids and colloids, so let's talk about what that means now. Crystalloid solutions are solutions that contain water and salts, and all of the solutions we've been talking about up to this point are examples of crystalloid solutions. They contain sodium chloride, which is an example of a salt. So fluids like normal saline, half normal saline, these are all crystalloid solutions. Colloid solutions contain water and some large molecule. For example, there are intravenous infusions available of albumin that contain albumin in water, and this is an example of a colloid solution. For years, people debated whether it was more effective to treat patients with crystalloid or colloid solutions. In general, the studies have shown no benefit of colloids over crystalloids, and for that reason, crystalloids are what are usually used. The reason is because colloids are expensive, and as I said, they have no proven benefit, so therefore we usually use crystalloids. I'll finish this video by briefly talking about hypo and hypervolemia. So hypovolemia is very common in hospitalized patients. There are many causes. Vomiting and diarrhea often leads to hypovolemia. Poor oral intake can do this. And finally, many patients have what's known as third spacing. Third spacing is when fluid leaks out of capillaries and into tissue beds, causing things like ascites and edema. And this occurs often in patients who have sepsis, trauma, and other conditions. On your clinical rotations, you'll get very comfortable making a diagnosis of hypovolemia based on clinical features. Some of the important ones I've listed here. First of all, patients who are hypovolemic will have a low urine output. It's very important to remember this in the hospital on rounds. We always carefully record the urine output in hospitalized patients, and the reason we do that is because it's an excellent indicator of volume status. A patient who is volume resuscitated is going to make urine. A patient who is hypovolemic is going to have poor urine output. Other clinical features that suggest hypovolemia are dry mucous membranes, poor skin turgor, and of course hypotension. And the treatment generally for hypovolemia is to increase the oral intake if the patient can do so, and administer IV fluids like what we've been talking about in this video. Hypervolemia is the other end of the spectrum. This occurs when there's too much fluid in the body. There are three classic causes of hypervolemia: heart failure, cirrhosis, and nephrotic syndrome. I've listed some of the clinical features of hypervolemia on this slide. First of all, weight gain. If patients tell you they're gaining weight over the last few days before they present for evaluation, that is a sign often that they are retaining fluid and that they are hypervolemic. Pitting edema in the lower extremities, like shown in this picture, is a sign of hypervolemia. So is elevated jugular venous pressure and pulmonary edema. And the treatment in most cases of hypervolemic states, especially heart failure and cirrhosis, is to administer diuretics so that this will increase the urine output and relieve the hypervolemia. And that concludes our video on fluids.